The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Welcome to the next episode of TMD Demystified. I'm Tony Urbanek. Today, we're going to talk about multidisciplinary treatment for TMD. TMD and multidisciplinary treatment. What is multidisciplinary? Just what it says. Having multiple disciplines associated with treating temporomandibular joint disorder. So let me remind everyone, if you're new to the episode, if you're new to this podcast, if you're new to watching this on either Dental Town or YouTube or listening on Spotify, this will be the 224th episode of TMD Demystified. There's a lot of information that preceded this, but and we have briefly mentioned multidisciplinary care of TMD before, but I'm going to try to expand on that, as they say, dissect it. I don't kind of like that. I think dissecting is left for frogs, or maybe in the pathology lab in medical school or dental school. But expanding on the issue, expanding on the topic, I think is very warranted here. If you've listened to any of those other episodes, you've heard me talk about the symptoms of temporomandibular joint problems. You've heard me say that TMD is a single diagnosis. It's not a series of diagnoses. TMD, temporomandibular joint disorder, singular. It's not a series of disorders, although there are many who would like you to believe that. There are many in universities and dental schools who would like you to believe that it's a series of disorders. I mean, just for example, they try to separate trigeminal neuralgia as a separate disorder when trigeminal neuralgia is nothing more, nothing less than a catch-all phrase primarily used by physicians acknowledging they don't know what the cause of trigeminal neuralgia is. Trigeminal neuralgia is simply a phrase which describes, in literally Latin terms, pain associated with the trigeminal nerve. It's a catch-all phrase. And you can define it pretty much any way you want because it's associated with the trigeminal, the three parts of the trigeminal nerve, which pretty much cover the sensory and motor areas of the entire face. So if you have a discomfort, a pain, a twitch, a tick, a burn, someplace around the head and face, I can promise you, if you take it to a physician, a PCP, a walk-in clinic, a nurse practitioner, a physician's assistant in a immediate care clinic, and describe some of these symptoms, they're going to call it trigeminal neuralgia without knowing anything more to say than, well, that must be trigeminal neuralgia. And then, you know, the pompous, I'll use that word, the pompous professors who want to make things difficult, complicated, want to make TMD a very complicated issue. And to enhance the complication of the issue they want to make it, then they want to make a multidisciplinary approach to treating it. The more people you bring into treatment of the problem, the more complicated you can make it. The more complicated, the more important you are if you treat it. And if it's complicated and you're more important, then you can strike a bigger fee. That sounds terrible, but I do believe that there are a group of individuals out there who use that theory, use that concept on why they make it a multidisciplinary approach, why they want to make it more complicated, so they can, one way or another, charge an inflated fee. But I'll let the listener decide that. Pretty much everyone out there knows the word or the concept, the three-letter identifier as TMJ. I think by now most people, but I know not all people, because we see our large volume of patients in this practice, large volume of patients who come to see us, most of the days 5 to 8 to 9 consults per day come in to talk about their TMJ issues, symptoms. Still a lot of people out there who only know it as TMJ. So, but the temporomandibular joint, everyone has two of those, is the seat, the place that the symptoms of TMD, temporomandibular joint disorder, originate from. So it's a single disorder. And as I've spoken on many times, I'm not going to repeat myself here, but the disorder actually is damage leading to chronic inflammation within the temporomandibular joint. That is the disorder. They're not multiple disorders. And then once you identify a damaged joint, the damage can come from bruxism, from acute trauma, and functional malocclusion. But all three of those categories damage, and they're the only three categories that I know of. They're categories of damage, and those categories damage the internal structures of the temporomandibular joint, which in turn create chronic inflammation. First, plain old inflammation, but when the joint does not go on to normal healing, like some areas of the body, when damaged, they create inflammation in the area, and inflammation goes on to heal, and then it's healed, and then it's not inflamed anymore. But within the temporomandibular joint, when it is damaged, and because of the chronic nature of the use of the joint, due to bruxism and or chewing or overuse of the joint or recurrent traumatic events, or especially functional malocclusions, the inflammation does not go on to normal healing, and the tissues within the temporomandibular joint, in particular the disc, meniscus, cushion within the temporomandibular joint, will not heal, which then the inflammation turns into different cellular exudates, different cellular types, different ratios of cellular types, that is called chronic inflammation. And chronic inflammation actually creates the symptoms. Chronic inflammation creates each and every one, directly one of the symptoms. Now, that is, I've just spoken on before, I'm not going to go through that scenario again, but it creates all the symptoms. And what the dental profession has attempted to do is to try to treat the problem only by treating the symptoms. And then it is made worse by then this concept of multidisciplinary approach. So if you have a symptom or a set of symptoms, you bring as many practitioners into the mix as you possibly can, using their particular set of instruments or expertise to address that particular symptom. And it varies all over the board. But this is actually getting out of hand, because it isn't a multidisciplinary approach that solves the problem. The approach is a singular direction, a singular set of research tools and observations and discoveries that show statistically, with a statistical study, independent study, that chronic inflammation creates all the symptoms. But again, the universities, the dental schools want to bring in psychologists, psychiatrists, physical therapists, prosthodontists, orthodontists, and oral and maxillofacial surgeons, and a few others who get together in unison, whether they be in the same clinic or pass the patient around between clinics, to address these separate symptoms. And if each of the disciplines has a set of tools, then their tool is applied to the symptom. For example, the tool of the psychologist is talk therapy. Psychologists don't prescribe drugs. Psychologists have a method to make a literal diagnosis on any psychological issue that comes up. They'll put a label on it, and then they will use their education and expertise. I don't claim that they're not educated, and don't claim that they're not have some expertise in their area, but because they have certain expertise in talk therapy, then that's what they apply to this thing called TMD. So the symptom of TMD, actually, it's not a symptom. Actually, it is one of the circumstances that enhances temporomandibular joint symptoms, which is stress. Stress is well known, well accepted by everyone. Stress, anxiety, worry can enhance or create bruxism, which is clenching or grinding. So the psychologist will jump on this and attempt to address the anxiety, worry, stress through talk therapy, which theoretically is supposed to decrease the bruxism. And if you decrease bruxism, being one of the primary circumstances that damages the joint, you can see the logic behind it, that if you decrease the bruxism, you decrease the damage. There are several fallacies about this, because once the damage is done, it's already done. And to throw in the mix, we do not understand how anxiety, stress, and worry creates bruxism. We know it's a neurological issue. We know that it is obviously mostly in the lower parts of the brain stem and slightly above, because a lot of people brux and are not even aware of it. A lot of people, and everyone has stress, but we do not understand. And if anyone actually can give me data, proof, scientific study that we know how anxiety and stress actually within the central nervous system creates bruxism, please let me know, because we don't know. We have theories. We have good neuroanatomists, neuropathologists who know the anatomy and pathology within the brain and the brainstem very well, but we do not know how stress and anxiety create bruxism. And even if you can give someone psychological discussions or training to decrease their stress, there is no way to show or prove that actually will decrease the symptoms. Even if you could prove it decreases the bruxism, the damage is already done, because it's all about symptoms. That's what the multidisciplinary approach is meant to do. I think the most common, and I think the most damaging part of multidisciplinary system is the use of drugs. And the issue with using drugs, again, can be prescribed by dentists. They can be prescribed by psychiatrists. That's one of the disciplines they bring into it. Psychiatrists can prescribe certain types of drugs that the dentist can't. Neuroleptics, depressants, antidepressants, SSRIs, and those drugs have tremendous side effects. But what happens is that there's no rhyme or reason to it. They prescribe a drug, throw it to the wall, and see if it sticks. And basically, again, the thinking behind it, I question whether there's any logic behind it, but the thinking behind it is if anxiety, stress is part of the problem, again, anxiety, stress, we know does create bruxism, is associated with bruxism. But if you suppress the central nervous system enough and long enough, then hopefully you can decrease the bruxism. But again, just decreasing bruxism doesn't fix any damage that is already there. Chronic inflammation is already there. But there are many, many examples. The prosthodontists want to reconstruct the teeth from the standpoint of, okay, teeth that don't fit together, which is defined, significant bite problems are defined as functional malocclusions. So if you straighten up the malocclusion by reconstructing with crowns and bridges, occlusal reconstructive devices, again, cuts down on the bruxism. Your teeth fit together, but not necessarily correct any symptoms. And then the oral and maxillofacial surgeons, of which I am one, and claim 2,000 temporomandibular joint surgery cases in the first 36 years of my 50-year career as a maxillofacial reconstructive surgeon. I can tell you exactly what the point of view of the maxillofacial surgeon is, and that is to reconstruct the joint one way or another, or to change the joint, temporomandibular joint, one way or another, to enhance its function, enhance or improve its function by adding things, by subtracting things, by reconstructing things, by repositioning things, by putting artificial things within the temporomandibular joint. And I've done all of those and more, to the point where I found out that a full third, at least third of my patients that I did surgery for would be back within a year or two with the same symptoms, which is the reason I quit doing temporomandibular joint surgery. I had plenty of other kinds of surgery to do, but I quit doing TMJ surgery because I couldn't look a patient, 90% female, in the eye and say, I'm going to fix you, when I knew that a third of those patients would be back within a year or two. And I quit doing surgery, and I did the research that showed that chronic inflammation creates all the symptoms. So you have a group out there who are mostly universities, who will, for the time being, go unnamed, but they know who they are, who promote this multidisciplinary approach, basically padding their economic success to the detriment of the patient, who goes from provider to provider to provider to provider, doing what that particular provider is expertise at, trying to handle just the symptoms. Botox is a good example. Botox, botulinum toxin A, the most common name for that drug, the generic drug, is Botox. Everybody knows it by Botox. And that's nothing more than paralyzing the muscles of the face, which, if muscle is paralyzed, it's not going to pull on the bone. It's not going to create a pain while it's paralyzed. And then that botulinum toxin A will wear off in 3 or 4 months, and you got to do it again. And now we know, with a scientific study behind it, that whether you put botulinum toxin A or saline into a muscle, it gives you the same effect. That I've spoken on before. So the multidisciplinary approach is primarily an approach that is becoming more common. Why is it becoming more common? Because the people who try to treat this really don't understand the cause, which I speak on, and no one disagrees with me. No one has contacted me, emailed, texted me to disagree or to show me other information that would prove or lead me to believe that chronic inflammation doesn't create all the symptoms, because they can't, because that's science. The science is out there. The orthopedic surgeons know about how chronic inflammation creates distant symptoms from the joint itself. Tennis elbow and TMD are the same disease. Tennis elbow symptoms are pain and burning in the forearm, not so much pain in the elbow. TMD is pain distant from the temporomandibular joint, which creates pain in and around the muscles of mastication, the face, then the neck, then the upper shoulder girdle, upper back and shoulder tightness and pain, all directed from, created by, through the autonomic nervous system, temporomandibular joint chronic inflammation. And the orthopedic surgeons know about this, and they call it joint splinting. They've known about it for 50, more like 70 years, but the orthopedic surgeons gave the temporomandibular joint to the dentist to figure out 70 years ago, and they never did figure it out, primarily because they started out from the point of view that this joint is different. They claim, they teach, they tell every dental student in the country that this joint is different, unique, it's complicated, and they can't figure it out. And that's their excuse, their justification for putting together a multidisciplinary. If one person can't figure it out, if one specialty can't figure it out, if one concept or group can't figure it out, like dentists, then it must be complicated. So let's bring more people into it, the multidisciplinary approach. It's actually dumb. It's a dumb logic. And now, again, unfortunately, the ADA, in their lack of wisdom, has actually agreed to and made oral facial pain a specialty within dentistry. This was about a year and a half ago. They've stated that oral facial pain is a specialty. Why? Because it's complicated. It must be complicated. We must make it a specialty. There's no need. If you don't have to be a specialist to treat TMD when you start out from the viewpoint that it's chronic inflammation within the joint, and the joint works like any other joint in the body. And if you can figure out a way to decrease the chronic inflammation, then you have this problem solved, because chronic inflammation drives the symptoms, and when you decrease the chronic inflammation, the symptoms go away. And that is how the orthopedic surgeons address it. If you have a bad knee and don't need or want knee reconstruction, total knee reconstruction, the orthopedic surgeon is going to put you on a set of crutches and say, if you stay on the crutches, your knee pain is going to go away. And if you have temporomandibular joint chronic inflammation, you don't need surgery. What you need is to unload the temporomandibular joint by disoccluding the posterior teeth according to a protocol, 24/7 for 2 months, then nighttime only the rest of your life. You're unloading the temporomandibular joint, which allows the chronic inflammation to decrease to the point where it doesn't stimulate the symptoms anymore, doesn't create the symptoms anymore. Symptoms of frequent or recurring headache, earache, jaw pain, neck pain, ringing in the ears, feeling of fullness in the ears, subjective hearing loss, vertigo, dizziness, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. And those are created through the autonomic nervous system, giving signals to the muscles to tighten up, and chronic inflammation infiltrating through the petrotympanic fissure into the middle ear, creating ringing, fullness, and dizziness. But when the inflammation in the joint goes away, each and every one of those symptoms dissipates and goes away. No need for multidisciplinary approach. No need for specialists to treat TMD. All you need is a little bit of knowledge, the use and follow up and follow through with a simple device that separates the posterior teeth according to a protocol, not just when the patient wants, but when according to the protocol, which is 24/7, 2 months, nighttime only the rest of the patient's life. And the multidisciplinary approach is not necessary. It's excessive. It's excessive attempt to make a rather simple problem complicated. Complicated in thought, complicated in diagnosis, complicated in treatment. Let's make it more complicated. Let's bring every kind of doctor we can into the system and let everybody take a look at the symptoms themselves. I think I've made my point. I want to make one final point I made before. I am ready to take criticism. I am well equipped to support my position on this to my colleagues or anyone else who would like to discuss this with me in a professional way. But so far, in the past 4 years since I've been doing this podcast, not a single doctor of any type has come to me, and I know that they are watching. I am positive they are watching. But no one has come to me to disagree or to show me anything that would dissuade me from follow through and showing the data and the science behind this. But I am available at Tony@tmjservices.net, or you can reach me through the website, which is www.urbanektmj.com. I don't think that the ADA is going to change its mind anytime soon about making orofacial pain a specialty, although that was a dumb idea. It doesn't have to be a specialty. You don't have to be a specialist to treat it. Again, to claim yourself as a specialist basically is an attempt to make yourself more important. Why do you make yourself more important? I'll let you make that decision for yourself. But no one has contacted me, even though I encourage it, to do anything about the problem. And unfortunately, I am faced on a day-to-day basis watching patients come through our practice who have been run around in circles by our dental and medical system and profession around this problem. The amount of misdiagnosis, misdirection, and mistreatment for temporomandibular joint disorder is amazing. Actually, so many patients have had decades of symptoms going from doctor to doctor to doctor. Multidisciplinary approach, whether it be organized multidisciplinary approach or multidisciplinary because the patient themselves go to multidisciplines, bringing these symptoms in front of these doctors, and invariably, whether they're treated or not, are not successful in solving the symptoms. And then they eventually make it into our office one way or another, either by referral or they literally stumble in due to Google. And then they find relief by using a very simple approach that decreases inflammation within the temporomandibular joint. And frankly, it's absolutely frustrating to see the constant line of patients who are not intentionally, but absolutely mistreated by the dental and medical profession in trying to diagnose and treat this problem. And the most recent attempt that they've been spooling up is the multidisciplinary approach to TMD. Frankly, not necessary. Frankly, it's nonsense. It's nonsense. All right. Hopefully I stirred your mind to think a little bit. Think about it. Use critical thinking. Take the data that I present and think on it critically. And again, criticize me if you'd like. I'm available. Tony@tmjservices.net. Until next time, we'll figure out another topic to address on this and these issues of temporomandibular joint disorder on this podcast called TMD Demystified.